Now just try sharing your screen. Just unmute also yourself now.
Just give me a few minutes. It's just preventing me just to share my screen. Just hold a minute.
Yeah, are you able to share?
Prof, my system is, I don't know why is it not, it's preventing me from sharing. I'm trying to remove the privacy of the system, and I've done that, but it keeps on saying to open the privacy. I've done that right now. I just don't know why is it not allowing me to do it.
Now your PowerPoint presentation has
Yes.
strict privacy settings, so you need to change that,
Okay.
because it was a confidential presentation which had an expiry time limit.
Oh gosh.
Hello, Dirk. Dirk, good afternoon.
Prof, if you have the link on your computer, are you able to share the screen? I don't know why is it not able to share. I'm
I will,
trying to.
I will, I will download it. It was in my email, but I will download it now.
Prof, just let me just update the system. It could be something to do with Zoom on the new Mac system. So I just want to just give me about 2 minutes. I've already granted permission to access the file on Zoom. I just don't know why is it not able to do it. So I think it has to do with the security update.
I have downloaded
Sure,
the
Prof.
presentation on my
Okay.
PC. So,
Okay.
so
Okay.
I just need to be able to access it. Give me another minute or two.
Sure, Prof. Prof, just let me leave the meeting. I'll just join 2 seconds. I just want to try something. I know what the problem is. Just give me 2 seconds, Prof.
Dirk, do you have a presentation?
Hello, Milind.
Hello, Dirk.
Yes.
Do you have a presentation?
No, Milind, I don't have a presentation for you. I was under the impression that one of your team was going to be presenting.
No, don't worry. You had a choice whether you wanted to have a presentation or not, but it's no problem at all.
Yes,
It's
no,
mainly Neha is going to present, and then we'll ask for your comments first, and then the comments of other colleagues. I see Sonia has also joined, so
yes,
we'll
absolutely.
ask for, yes, so we'll ask for her comments and the comments of my other consultant colleagues also. So
Perfect. Yes, exactly.
so Neha, it looks like you have sorted your problem. Am I correct?
Yes, Prof. Technology. It's a bit
Okay,
complicated
so
now.
you can stop sharing for a minute. Then I will introduce Dr. Dirk van der, and then you can share again.
Okay.
Neha, can you hear me?
I can hear you.
Okay. Good afternoon, everybody. Sorry for the technical glitches and little bit of delay in starting the meeting. I welcome you from very windy, quite cold East London, and luckily quiet so far. But we are really worried about the situation in the rest of the country. I hope it gets under control as soon as possible. This afternoon, evening, Dr. Neha Gautam, who is one of our junior staff members, is going to give an overview of congenital lung lesions. And I'm really very happy and very excited to have Dr. Dirk van Delft, who is a consultant pediatric surgeon at the Red Cross Children's Hospital in Cape Town, affiliated to the University of Cape Town, and who is our invited guest for this meeting. And Dirk is as caring as this photo on his Twitter account shows. He is a very modest and humble person. He joined our department as registrar in 2009. And we are really very glad and proud to say that we did, or he did, the complete training in East London with Dr. Lazarus, myself, and Dr. Simango. But Dirk had experience in thoracic surgery. He had worked with Dr. Sonia van Reet. I'm glad she is able to join us today. Before he went to the UK, and he did real research in the UK. Then he came and joined us. And while he was here with us for about 5 years, he taught us many things. And a couple of important things which he taught us was how to do a bronchoscopy properly using the camera system. And also, he was the one who taught us to do the pair procedure for liver hydatids. Dirk cycled from East London to Cape Town, which is a distance of 1,000 kilometers in straight 5 days, 200 kilometers every day. And with this initiative, he raised 100,000 Rand in 2009. which was quite a significant amount. And we could buy our endoscopic equipment through that donation. But that also actually set the ball rolling in our mind, and that prompted us actually to start our Yabantwana for the Children Trust. So since then, he is like an eternal friend of the Department of Pediatric Surgery. At a personal level, Dirk is a very close family friend to most of us, not only people working in the Department of Pediatric Surgery, but also lots of medical and non-medical people in East London. And we are really very eagerly waiting for Dirk to visit, possibly with his family, when this COVID nonsense is finally over. Dirk is a keen cyclist, we know about it. He is a musician, he plays cello quite well, and he has also conducted fundraising musical events for our trust. He says he's a traveler, and I know he's a committed family man and a loving and a very proud dad to little Finn Theodore. So Dirk, we are really very happy to have you with us today. So I will stop sharing my screen now, and I will invite Dr. Neha Gautam to share her screen and give an overview of congenital lung lesions. It's quite a vast topic. We have tried to edit and trim as much as possible. So after her presentation, I will invite Dr. Van Delft, then Dr. Sonia van Reet, who is a cardiothoracic surgeon who is affiliated to our hospitals, and then other consultants from our department and any other consultants. So any of the attendees who have a question, a comment, please just post it in the chat box, and I'll try and get Dr. Van Delft or Dr. Van Reet to answer the questions at the end of the discussion. So Neha, thank you. We are all ears for you.
So good afternoon, good evening, everybody. And my topic will be dealing about congenital bronchopulmonary malformations. I'm from East London in the Department of Pediatric Surgery. So the incidence of congenital malformations of the lung has increased in the recent years based on several population-based studies, which suggest a frequency of 1 is into 25,000 live births. This is still a very rare anomaly. From a registry done by Kunisaki and his colleagues, where he had collected 344 patients, he talks about congenital pulmonary airway malformations are the most common cystic lesions of the chest in a neonate. And then this is followed by bronchopulmonary sequestrations and congenital lobular emphysema. Also, hybrid lesions make a portion of these cystic lesions. The differential diagnosis of a prenatally diagnosed cystic lung lesion can be very confusing, and it can often be very difficult to diagnose on X-rays. It also may mimic conditions like congenital diaphragmatic hernia. So the differential diagnosis extends from congenital pulmonary airway malformations, as well as bronchopulmonary sequestrations that actually present an area of non-functioning lung tissue that do not communicate with the tracheal bronchial tree and have a systemic arterial blood supply. This also may mimic congenital diaphragmatic hernia. The difference being that congenital diaphragmatic hernia are generally left-sided lesions. They have an associated pulmonary hyperplasia. They look very similar to cystic lesions on X-ray. And one can differentiate from cystic lesions in the presence of bowel content in the chest, or an X-ray seen in this X-ray on the screen, a nasogastric tube in the chest. And if one wishes to do a contrast swallow, one can also demonstrate bowel in the chest. Then the last other twos that make it quite confusing is congenital lobar emphysema. And this is characterized by air trapping an overdistension of one or more pulmonary lobes, and is possibly due to some defect in the bronchial cartilage. And then foregut malformations, the most common being a bronchogenic cyst, and is a malformation of the bronchial tree. This can present as a mediastinal mass that may even enlarge and cause local compression. So the way cysts are being classified is the historic classification mentioned by Stoker. He describes the lesion by means following lung resection. So he uses a histological classification. He described 5 different types of cystic lesions, with type 1 being the most common. But now what is current is ADZEC. ADZEC is the current classification that is based on antenatal findings. The main factor is actually the size of the cysts. He mentioned 2 different sizes. Those are macrocytic and microcytic. Macrocytic being more than 5 millimeters and microcytic being less than 5 millimeters. So in order to actually understand the origins of these congenital lesions that appear, one needs to have a complete understanding of the embryonic origins of the developing lungs, and this will help to understand where these anomalies did originate from. So as early in the 3rd week, in the embryonic phase, the lung appears as a ventral outpouching of the endoderm foregut. And by the end of the 4th week of gestation, the caudal growth of the respiratory diverticulum becomes separated in 2 different cavities, that being the oesophagus and that being the trachea. And this is separated by means of a tracheal oesophageal septum. The larynx, which develops from the 4th to the 6th branchial arches, maintains communication with the trachea. The pleural cavities are formed on either side of the foregut by caudal migration or the developing lung bud into the abdominal cavity. The pulmonary vasculature develops in the mesoderm at about 7 to 8 weeks, and the lung buds develop bronchial buds in the 5th week. And soon the bronchial division starts and completes itself towards the mid-trimester. Eventually, the last thing is the terminal airways develop until early childhood from 8 years of age, of which gaseous exchange is eventually possible by 7 months of gestation. And then eventually, the overall maturation of the lung can be separated into 4 distinctive periods. The first phase being the embryonic phase, which is where the lung bud becomes to differentiate. The pseudoglandular phase, with the formation of formal lung buds and terminal bronchi. The cannular stage, which is the development of the vessels, the bronchioles, and the alveolar ducts. And then the saccular stage, which is maturation of the alveolar sacs. The alveolar stage extends from birth and then stops between the age of 2 to 8 years of age. So the way I intend to approach this talk is I will be looking at a case study. We will focus on the antenatal management, and then we will focus the case study towards the postnatal management, and can give you examples of how these cystic lesions present antenatally and also postnatally. So the first case study is looking at a cystic lung lesion, and the case study goes as such. A 38-year-old woman goes a prenatal ultrasound at 23 weeks of gestation, and this demonstrates a left pulmonary mass in a female fetus. She is otherwise well. On the ultrasound, the mass appears to be located in the left lower lobe, and it consists of cysts of variable sizes. It measures 22 by 17 by 10 centimeters. So the thing to ask about this clinical case is what other information you would like to obtain from the ultrasound prior to meeting the couple. To answer this, what is very important is the Cpam volume ratio, or the CVR ratio. And the purpose of this is to quantify the size of the mass adjusted to gestational age. And this is a simple calculation that is using the length, the height, the width, times by 0.52 and divided by the head circumference of the fetus. Other information you would like to look on the ultrasound, or even in a developed country where they use fetal MRI, is there any possibility or the presence of mediastinal shift, diaphragmatic flattening or inversion, pleural effusion, features of hydrops, or a systemic feeding vessel? And all these important findings on the initial and follow-up ultrasounds will actually help you to prognosticate and plan for possible need of a fetal intervention. So when we focus on very large macrocytic masses before 28 weeks, these obviously have higher CVR scores. So that's above 1.6. They compress the esophagus, they lead to polyhydramnios, they displace the normal lung, and they cause associated pulmonary hyperplasia. At the same time, these lesions compress the vena cava and the heart and can cause low output cardiac failure, which has led to a condition called hydrops fetalis. So hydrops is defined as a fluid collection in two or more compartments in a fetus, and it can present with fetal ascites, pleural and pericardial effusion, skin or scalpedema. So the options of management in such a clinical scenario is the use of maternal steroids that have been shown to be beneficial and produce good outcomes for the fetus. They obviously shrink the mass. But then the role of fetal intervention usually is indicated when, despite these medical management, hydrops and cardiac failure do occur and does present. The options include things like thoracentesis, shunting, and even laser ablation of the feeding vessels. However, in macrocytic masses that present more than 28 weeks of life, they do not require fetal intervention, but still they remain large. And we perform repeat imaging at least 32 to 34 weeks of gestational age. And we look for any signs of developing prenatal cardiorespiratory distress. Such patients will be offered an exit procedure and then will then lead to a resection procedure, or these children need to be born in a center where ECMO is available. So exit, which stands for extra-utero intrapartum treatment. And the concern of why we consider this procedure is the compressed, uninvolved lung of a fetus with persistent large mass may actually not provide sufficient ventilation. If any positive pressure airway is used, this may actually increase the cystic lesion, especially a Cpam, and increase the mass effect on the normal lung and even the heart, and can actually worsen the heart and lung function. So as you see in this picture, first thing, a lower abdominal or a phalansteal incision is done, and this is followed by creation of a hysterotomy. The fetus is then delivered, is intubated, and intravenous access is obtained while on placenta support, and then a posterior lateral thoracotomy is performed, and where the lesion or the cystic mass is exteriorized from the chest cavity. Ventilation is attempted, and the fetus is then taken out of the delivery room and transferred to an adjacent operating room from completion of the further surgery. So now we get into the postnatal management. And these are typically the lesions that had not caused any fetal compromise in the antenatal period. And we've regularly followed them up with ultrasounds, and we come to closest term to deliver the baby. So in the same case study, eventually the fetus progresses well. The CVR increases to a maximum of 0.64, which is low, during the early third trimester, but it decreases over time. There are no complications seen in the fetus. The baby girl is born via spontaneous vaginal delivery at 39 weeks of gestation. She has no respiratory symptoms, and her vital signs and physical examination are completely normal. And then a chest X-ray is performed at 48 hours of age, as seen on the slide, and it actually reads normal. So the question to ask, does this actually imply resolution of the lesion? So to answer this, a near normal or normal chest X-ray is a very frequent finding in an asymptomatic Cpam lesion. Eventually, relatively large ones will actually have issues with mediastinal shift. So this does not imply any disappearance or regression of the lesion. What is actually essential is that such a patient would require a CT chest as further imaging. This will help to define the mass anatomically, plan for surgery, and also understand if any feeding vessels are present in relation to the systemic or pulmonary vascular system. So the other question to ask, what is the necessary follow-up that this patient would need? So this baby is asymptomatic and is likely to remain so early in life. But eventually between ages of 3 to 4 months, she's required to get a CT scan to actually give more detail of the lesion. So the management of such lesions is that I want to stress that resection is priority and is advised within 3 months of age, even in an asymptomatic patient that has been shown that in a child's lifetime, they may in fact present with life-threatening complications. So immediate resection is advised immediately in a symptomatic infant. Surveillance and non-operative management may happen, but it requires regular CT and X-rays that actually, in fact, imposes unnecessary radiation to the infant. So therefore, resection is priority in such patients. So the next case study will be looking at a 30-year-old female, and she presents presents to you at 22 weeks of gestation. A recently performed fetal ultrasound shows a distinct echogenic structure in the left thorax of a female fetus. This is compressing the diaphragm. It measures 1.7 by 1.7 by 2 centimeters and is associated with a discrete feeding vessel. There is slight shift of the heart to the right, but no pleural or pericardial effusion, so no hydrops. Amniotic fluid volume and the remainder of the fetus survey are normal. So how we intend to actually manage this? So an intrathoracic mass in a fetus has a wide differential, as you see on the screen. But in the absence of a cystic appearance on the fetal ultrasound and the presence of a discrete systemic feeding vessel, the most likely diagnosis is a bronchopulmonary sequestration. So in this ultrasound, this is actually a small bronchopulmonary sequestration. What we would need to do is we would need to follow up the infant, the baby, bi-weekly with ultrasounds and see if the baby is progressing well. But what happens in this case study is the mass is still seen on the ultrasound towards end of pregnancy by 36 weeks. But eventually we reach 40 weeks, the baby is born. The baby is completely asymptomatic, her physical examination is normal, and a chest X-ray is done on the second day of life prior to discharge. So as you can see on the X-ray, it's really difficult to actually define the sequestration, and even the baby is completely asymptomatic. So once again, I want to stress that she would need further imaging later on, like a CT chest, to define the mass. So when it comes to bronchopulmonary sequestrations, they make up 10 to 30% of congenital cystic lung lesions. They are solid, they're non-functioning congenital lung lesions, and they have a good blood supply that originates from the aorta and rather than the pulmonary artery. They also have their venous drainage that may come through either a systemic or pulmonary vein. The identification of a systemic arterial blood supply, usually from the thoracoabdominal aorta, is pathognomonic for bronchopulmonary sequestrations. There is an absence of communication with the bronchial tree. And these sequestrations can be divided into two groups. These are intralobular and extralobular. So extralobular sequestrations are most commonly found in the left lower chest with 80 to 90% above the diaphragm and 10 to 20% below. The aberrant blood supply is mainly from the thoracic aorta and 20% arise from the abdominal aorta as a systemic venous drainage to the azygous vein or the inferior vena cava. They have associated anomalies such as diaphragmatic hernia, cardiac defects, AV malformations, and other anomalies are even present up to 60% of extralobular sequestrations. These lesions are often asymptomatic at birth, but because of AV shunting, they may actually develop hydrops fetalis prenatally. Usually the chest X-ray typically will depict a left posterior mediastinal mass. However, once again, further imaging is needed, especially a contrasted CT, to once again define this mass. Intralobular sequestrations usually affect the medial and posterior segments of the left lower lungs with an aberrant vessel from the thoracic aorta and pulmonary venous drainage. Presentation includes non-resolving pneumonia, lung abscess, and rarely hemoptysis. Chest X-ray will actually demonstrate non-aerated ectolectus mass, and a contrast CT is still to confirm the mass with a potential blood supply. So when it comes to the surgical management of such lesions, understanding the blood supply and the venous drainage of the two types of sequestrations will actually predict the approach to surgery. So the means we can do is thoracoscopy or open is an ideal approach for these lesions. For the intralobular types, one should resect or perform a lobectomy. If the sequestrations are in fact small and peripheral, segmentectomy can be considered. For extralobular lesions, the entire mass must be excised. And in all cases, control of the systemic arterial circulation should proceed first. There has been talk in many studies about embolization of these sequestrations. Indications are not well established still, but this option may be suited for the patient that is in high output heart failure. And eventually this lesion will regress, so therefore the need of surgery may not be required. The outcome of surgery is usually excellent, except when the patient had been presented with other pre-existing complications like infection. The complications include air leaks, residual disease, infection, and any damage to the adjacent structures are noted as complications. Then when it comes to congenital lobar emphysema, this is characterized by air trapping and over-distension of one or more pulmonary lobes, possibly secondary to a defect in the bronchial cartilage. This lesion commonly occurs in the left upper and right middle lobes. The typical postnatal presentation is of respiratory distress from ectolectasis, secondary to lung compression, or even wheezing, or even a tension pneumothorax. Diagnosis is confirmed on chest X-ray, and one recommends an echo should be performed, as 15 to 20% of these patients presenting with this condition will have an associated congenital heart disease. Resection is required of the infected lobe due to complications that develop later on. And then the last case study is, I want to mention, is a 2-month-old girl. And she gets managed by the medical pediatric team for stridor. She is placed on IV steroids for the possibility or the diagnosis of epiglottitis. But 3 days later, she presents to the surgical team with hematemesis. Her HP drops from 10 to 8. She's adequately resuscitated. She's placed on a proton pump inhibitor, and she's followed up by upper endoscopy. And then you can see the two images attached. It's an X-ray as well as CT. And what the surgeon noticed on his endoscopy is that an abnormal or an unusual angulation of the esophagus. And then he also notes the diffuse gastritis. He then performs a CT chest. So the CT chest findings find a cystic mass seen at the level of the carina and the arch of the aorta, resulting in extrinsic compression of the distal trachea. The mass is simple, it's well circumscribed, it's like a cyst, it's free of any septations, calcifications, or any solid component. The most likely etiology of a simple cystic mass in close association with the trachea and the esophagus is most likely a bronchopulmonary foregut malformation, such as a duplication cyst, or even more commonly a bronchogenic cyst. When it comes to these bronchopulmonary foregut malformations, they comprise a wide spectrum of congenital cystic anomalies of the mediastinum. These malformations include the entities referred as bronchogenic cysts, foregut duplications, oesophageal duplications, and enteric duplications. These cysts are in close proximity to the trachea or the bronchi, and they do not share a common wall with the esophagus. They contain their own cartilage, and usually histologically they are diagnosed as a bronchogenic cyst. They can produce a mass effect that can be mild, but if these lesions are identified below the carina, they may even cause life-threatening airway compromise. Complications associated with bronchogenic cysts include infection, malignancy, hemoptysis, hemothorax, and pneumothorax. For all these reasons, these complications I've identified, all bronchogenic cysts should be resected regardless of the clinical presentation or age of diagnosis. If infants or neonates are symptomatic, they require immediate resection or even aspiration of the cyst as a temporizing measure. Asymptomatic newborns with a bronchogenic cyst identified on imaging can be followed up as an outpatient, and they can be scheduled for an elective resection after a month of age. Older patients should undergo resection of these cysts as soon as possible when the diagnosis is made. These lesions can be safely resected using thoracoscopic techniques or even open techniques. When the cyst cannot be completely resected, the mucosal layer should be excised, leaving behind only the peripheral connective tissue to eliminate the risk of reoccurrence and malignant transformation. So just to understand what is actually better, thoracoscopic versus open surgery. So I've looked at a recent retrospective comparative study done in 2021 on the differences between thoracoscopic and open surgery. So the study looked at intraoperative variables and measured the two groups. So the variables they looked in theater were the length of the surgical incision, the blood loss, and the operating time. So in all these three parameters, thoracoscopic or minimal invasive surgery was obviously favored. But however, the post-operative variables were looked at as well. So they looked at ventilator days, they looked at duration of the chest tube, and the length of post-operative hospital stay. And these two groups actually were not different from one another. They were almost equal. So I want to conclude is that despite the advantages of thoracoscopic surgery, it is very beneficial. But as a surgeon, you need to be competent in also open surgery. Thoracoscopic surgery requires significant skills and expertise for a surgeon who's competent in minimal invasive surgery in infants. So for the conclusion of this talk, cystic lung lesions are rare. The accepted classification is now descriptive. A chest X-ray may diagnose most symptomatic lesions. However, if only 60% sensitive in detecting prenatally diagnosed asymptomatic lesions. A CT chest where available should provide better imaging of the lesion. Symptomatic lesions require surgical intervention, and the management of asymptomatic lesions is controversial. However, most institutions recommend operative treatment early. Lobectomy or segmentectomy is the treatment of choice in most conditions. Morbidity is due to air leaks and infection, but overall, the outcomes are good. Thank you.
Neha, thank you very much. That was a vast topic, as we knew. And under the guidance of Dr. Yashoda Manikchand, our consultant, you did quite well to give a nice summary with very interesting imaging photos. So well done. I will invite Dr. Dirk van Delft to give his comments first. Dirk, please go ahead.
Milind, thank you very much, and thank you for the very kind introduction you made. I hope you can hear me. Yes, the topic of these congenital lung lesions is indeed a big one, considering that they are so very rare. situation that we find ourselves in South Africa, and I think for many people in poorly resourced or limited resource settings, we will see very few of these lesions, and the services that we work in will not recognize as many of these lesions as one would see elsewhere. And as you pointed out, I had the fortunate opportunity to work in the United Kingdom and subsequently in Australia, where the antenatal diagnosis, of course, is the big pickup. And this is the first point I would like to make, is that I'm very glad that Dr. Gautam pointed out that the diagnostic description and criteria have moved away from the Stoker classification, which is ultimately not very helpful if you can only classify the lesion once you've operated on it. And so using a descriptive lesion such as the one provided by ATSIC is very useful. And I think the other thing that has been a big advance in the diagnosis and pickup for these lesions is antenatal screening of otherwise healthy pregnancies, where one doesn't expect to find anything, but where screening is a routine process. And from that, one has noticed is quite a lot bigger than one would see in the live births. And the natural history of these lesions has been described in a way, and we know that many of them will regress completely, which also leaves us with some questions as to the antenatal management. And what Dr. Gautam has very beautifully illustrated is the most extreme case, so a very big lesion with all its associated complications before the 28th week. But those, in a set of extremely rare malformations, are the very rare presentations, the fetus in distress. And that is a fortunate thing, because for us, especially in a setting where we don't have antenatal fetal interventions, apart from maybe steroids, which don't work as well as we would like to believe, there's not much else we can do. But fortunately, the majority of these fetuses will be uncomplicated and will come to term. And then I think the controversy, or the topic that most people want to skirt, and when we read on the topics, we quickly make up our mind which camp we sit in. We're either decide that we are going to operate on all of these lesions as early as possible, because after all, we are surgeons, so that's what we like to do, versus the group that is a little bit more circumspect about this, who feel that because we know much more of these lesions, and because predictably many of these lesions tend to become smaller and either go away or cause no harm at all, there is a group of which Professor Andy Bush at the Brompton Hospital for Lung Diseases in Children is a great proponent, is to follow up the majority of these lesions. And of course, I want to make the proviso that we understand the bronchogenic cysts and the foregut duplications, or the foregut malformations, such as those of the esophagus, are mostly symptomatic and therefore will fall into the category that deserve their excision. And then I think one final comment, and then I'm happy to take questions, and I think Dr. Gautam should take questions as well, is that although thoracoscopy is very some of these lesions, and certainly changes the long-term outcomes of the chest wall and the spinal column in terms of long-term complications of open surgery, it is not all that easy, especially if one elects to operate early on. So I want to caution those surgeons who want to embark on thoracoscopic surgery to know their way around the chest extremely well before you embark on your first procedure, and to know the anatomy of the lung, and to know the anatomy of the bronchial blood supply and the major vessels draining the lung and supplying the lung itself, so the pulmonary artery. Because getting lost and disorientated in the chest can be one of the most problematic things during thoracoscopic surgery, and missing a vessel or otherwise taking down a vessel to one of the lung lobes that one had not intended to resect, certainly is a grave complication that should be avoided. So while I'm a great proponent of thoracoscopic surgery, and I think it has a place, I think one needs to be very, very well versed with its limitations and with the anatomy in the chest before one embarks on in the chest, and select one's patients very carefully. Thank you.
Dirk, thank you very much. Really, I'd just like to highlight two very important things which you have said. Is always the middle path is probably the best path. The pendulum keeps swinging in these gray areas from radical surgery to total conservatism, and then sometimes later it comes in the middle, and then you do watchful observation and do surgery as and when necessary. So I think very important principle you highlighted. And the second important principle you highlighted is the one which probably Sonia taught us when she used to visit us from Johannesburg, and I mean, you did a few cases with her, and I distinctly remember she teaching us the same thing which you have just verbalized, is be paranoid, try and identify the vessels before you ligate them, and know your way around. So I think very important words of caution about overzealous young, probably not so young surgeons who want to prove that they can do these things thoracoscopically. But as it goes for everything, you need to be a proficient surgeon for open surgery before you embark on endoscopic surgery. So thank you for highlighting those two things. And I see there is an excellent comment from Dr. Meera Menon, who is actually a qualified pediatric surgeon from Christian Medical College in Vellore in India. And she's currently working in Albany Hospital in New York. And she says that we need to remember that pleuropulmonary blastoma differential diagnosis, we need to remember that as a differential diagnosis, and it will need early surgical intervention. So that's something quite important. I will now invite Dr. Sonia van Riet to make her comments. Sonia, please unmute yourself and then give your comments. Sonia still around?
Milind, while you're waiting for Sonia, and please let me know as soon as she appears, I think the comment about the bronchopulmonary blastoma is very important and very interesting.
Yes.
And this is one of the topics that is often raised about especially Cpams and the hybrid lesions that drives many surgeons to operate early. And I had the privilege of speaking to Professor Andy Bush, who's done a lot of research on this and has a lot of experience also about the genetics related to bronchopulmonary blastoma. And the two comments are, the one being, if these lesions should ever turn malignant, they will do so late in life, so in the fourth or the middle of the third or the fourth decade. Therefore, there is no reason to operate on them early. And second, that with hardly an exception, these bronchopulmonary blastomas are associated to the DIASA1 gene. And the DIASA1 gene is one that one can test for. And therefore, if one is concerned about malignant transformation of one of these lesions, so that if one is concerned that one should miss the diagnosis of bronchopulmonary blastoma, all one need to do is do the genetic testing. And if there is no DIASA1 gene association, then one can, with a good conscience, follow up these lesions that would fit into the differential diagnosis of bronchopulmonary blastoma. So I think Dr. Menon's comment is very valid, and there is a lot of good conversation to be had around this topic specifically. Thank you.
Thank you, Dirk. I think that's very useful. Sonia, I don't know whether she can hear me. I'm unable to unmute her. So Sonia, please unmute yourself and give your comments. I don't know whether she can hear me. While we are waiting, we are also honored to have Dr. Basil Brown, who is a cardiologist who works in Port Elizabeth. So Dr. Brown, do you have any comments, any questions to Neha, to Dirk? Dr. Brown still here? Dr. Brown, please unmute yourself. Dirk, can you hear me?
Yes, Milind, I can.
I don't know why the colleagues are not able to hear me, but why? Okay, Dr. Brown, Basil.
Hello, I am Basil Brown, but I am in the Caribbean, a pediatric surgeon in the Caribbean in the country of Guyana. I don't think I'm the Basil Brown you were expecting.
Oh, okay, okay. No, but wonderful to have you. So please give your comments if you have any.
At this time, no. Thank you.
Okay, thank you. I will then invite Dr. Yashoda Manikchand, our consultant pediatric surgeon, who has actually mentored Dr. Gautam in preparation of this talk. Yashoda.
Hi, Prof. Thank you. And thank you to Neha. That was very well done. And I thought the case presentations were a more interesting way of exploring topics. So that was nice to see all the images. No, I don't really have any comments except that, like Dirk was saying, we obviously don't see a lot of these lesions now because of the poor antenatal screening in our setting. But we are going to start seeing more, I'm sure, as the antenatal screening gets better. We hope that it is getting better. So it's important for all us pediatric surgeons to be aware of these lesions. And obviously, the differential diagnosis of the esophageal duplications and the CDH is important for us to rule out these lesions. Thank you.
Yashoda, thank you for the comment. I fully agree with you. And over last 26 years, since we have been in East London, there has certainly been improvement in the referrals in general about such thoracic conditions. So certainly doctors are suspecting them and then trying to refer them to us. So I'm sure in the years to come, antenatal diagnosis will also become more widely available, and soon we will start getting referrals about antenatally diagnosed thoracic lesions. I will invite Dr. Majola, who is our other consultant pediatric surgeon, and he in fact has some local experience of doing thoracoscopic surgery. We haven't done a lot of thoracoscopic surgery in East London, but I think Dr. Majola has done at least a couple of cases, not directly congenital lung lesions, but he has done repair of a diaphragmatic eventration. So Dr. Majola, your comments?
Hi, Prof. Thank you. And thank you to Neha for a well put together talk. Very informative and just quite a reminder of the conditions that we hardly ever see, and also that they are rare, but also something that we need to look into with the hope that our antenatal screening might improve and that we might actually start seeing quite a few of these cases. And yeah, as Dirk had said, it's quite easy to get lost in the chest, especially when you do thoracoscopy. So it's very important that you know your way around so that when you do get lost, you have references of trying to find yourself in there. Just one question to Dirk, as it has been sort of illustrated. Obviously, the symptomatic ones, there is no two ways about it. You have to operate and take them out. But the ones that they do follow up, is there sort of time period that they will watch it for how long before they get in and operate if they don't get symptomatic or complicate? So would it be after a year or at 5 years of age? Because as we know, the lesion is there, although they might become smaller, but it doesn't really disappear. So is there like the sort of cutoff age as to, at this certain age, we will need to have taken it out because of a later complications of malignancy? Thanks.
Thanks for the question. So no, it's not an age-related decision that one takes. I think if one has decided to follow the lesion up, the criteria for intervention would be if the lesion increases in size, or if a normal or hemoptysis, abscess formation, etc. The question of malignancy, as I've alluded to, is one that one can resolve in the majority of cases by genetics. And yes, there are the odd cases that have been described where it becomes a squamous cell epithelial carcinoma. Those cases are exceedingly rare. And so it is, I think the indication to operate because of a concern for malignancy, that is a very small indication. I think another indication that one needs to think about is the patient's own fortitude to live with a lesion that they know they have in their chest. And if one's initial counseling is very good and there is reassurance that one will not abandon the patient and that the follow-up examinations reveal that the lesion is not changing in size and is causing no symptoms, then many patients will tolerate living with the lesion, but there will always be those that would rather have the lesion out. I think what is important then is to know very well what the rate of complications for these lesions. And the rational concern would be that if the rate of complications is higher for surgery than for the lesion doing something bad, then most people would say, well, then don't operate on the lesion, because the chance of you doing something that is that doesn't stand the patient in good stead is more than what would happen if you'd left the lesion alone. Then that math is quite easy to do. Those are the consideration, is that one may say the lesion isn't very big at this point in time, and over time it does not grow, but what is the consequence to the lung function or the functional residual lung volume? And that again can be resolved with lung function tests. And if there is a significant reduction in lung function as compared to age matched controls, and these lung function tests are available on normograms, then one could make a case for early resection. So that would be before the age of 4 years. The difficulty there is that, so certainly from 2.5 years onwards, many children are able to cooperate very well with modern lung function testing and with the way that they are trained to cooperate. And then you would need to see a big discrepancy in lung functions between the index patient and the norm for that age group. So again, and you would need to operate before the functional lung development has stopped. So the indications, once you've decided to watch a lesion, they become dwindling, apart from those that develop a complication.
Okay, thank you very much.
Yes, Dr. Majola, any other comments?
No other comments, Bob. Thanks.
Thank you for pointing that out, that there are multiple factors which we pediatric surgeons need to consider. There are some factors related to the lesion per se. Then there are factors, as you clearly mentioned, about the patient and the family. And then there are factors about the feasibility of follow-up, and all those things will actually contribute to your decision making. But I think you also correctly highlighted that, as our Hippocratic principle says, do no harm. So if our possible complications of surgery are going to be more radical and disastrous, rather than waiting for a lesion which may already have started decreasing in size and is completely asymptomatic, then we should be observing that lesion. I see there is another nice comment from Dr. Meera Menon, is that one of the challenges of thoracoscopic intervention in infants is one lung anesthesia and availability of an experienced pediatric anesthesiologist. And that's very valid. And also availability of specific types of endotracheal tubes. So that's very important. And now we'll invite Dr. Sello Machaya, who is our another consultant with quite proficient skills in endoscopic surgery, to give his comments or ask any questions. Sello?
Hi, thanks, Prof. Thanks, Nea, again for the presentation. It was nicely done. I think what's important, what I've always battled with, is trying to actually make a diagnosis of this condition, because once you see them with the X-ray, and the child is in the respiratory distress, the symptomatic ones, that is, they're in respiratory distress, and because from ped surgery, or if you're in centers where you have cardiothoracic surgery, they won't be sending us these kids. They'll probably send us a CDH. So we're so used to looking at an X-ray and seeing something that looks like an abnormal left hemithorax that looks like it's bowel maybe in there, that we forget everything else. And the important, I think, behind this talk is to kind of remind us that as much as there are cardiothoracic surgeons who can primarily handle or primarily deal with these pathologies, you should always bear it at the back of mind, because the repercussions and consequences would be quite rather dire if you assume a Cpam is actually a CDH, because you're so used to seeing those pathology. But also I want to just echo what everyone has been stating. You must be very, very proficient in doing anything thoracoscopy or even laparoscopy. You must be proficient to do it open before that, as much as with how things are going nowadays, there's a tendency of moving towards minimally invasive surgery with its good outcome and so forth. But I think it's extremely important to be able to be competent with any procedure open, and that'll make you a safe surgeon, and it'll obviously counter in your favor of being a good thoracoscopist or laparoscopist. But ideally, all I want to say is that it's good to always think back of your mind that that differential might not be that CDH that you're so used to. It might be something else, and to investigate it further thereafter. Thanks, Prof.
Sello, thank you. That was very, very appropriate advice. And now we are lucky that Dr. Sonia van Reet is our full-time cardiothoracic surgeon stationed in our hospital. But she has been there only for a couple of years, if I'm correct. And before that, as you correctly pointed out, we need to think out of the box of congenital diaphragmatic hernia, and need to remember that even though rare, other lesions do exist, and we pediatric surgeons need to know the basics of these lesions. And as you correctly said, we should not try and operate on the Cpam thinking it to be a diaphragmatic hernia or an extralobular sequestration, and then damage a big vessel which is coming directly from aorta, and avoid disaster. So thank you, Sello. I don't see there are any other comments or questions. So I'll just request Dr. Dirk van Delft to say his concluding remarks. The meeting is recorded. So if anybody is interested in having access to the recording, please just send an email to Tristan, and soon we will, in fact, I usually save these recordings in a Google Drive, and we will share the link of the Google Drive, but feel free for that. So Dirk, your final comments, please.
Yes, I would like to wrap up then that these lesions are rare. They are very interesting. And I think we mustn't feel despondent that we don't have the antenatal fetal screening that other places have. I think we should rather be encouraged to get to look at the plain chest X-ray with very critical eyes, and pay attention to those children who are referred with what look like atypical pneumonias or lesions that are suspicious in any way. I know we're all very used to thinking about tuberculosis and recurrent lung infections or empyemas. Those are common fare for us. But unless we look at these lesions very critically and try and pick out those that might be something else, we will continue to see only few of these lesions. And certainly they are there. One must just become very used to looking at chest X-rays extremely carefully in our setting. And then the second comment is that when one has a suspicion, it is well worthwhile to discuss this in detail with one's radiology colleagues, because the way that the chest CT is done is also critically important. It can't just be a hit and miss affair. One really wants to get the modes and sequencing completely right to pick up the systemic vessels. And then finally, I think that they remain very interesting lesions, and there's a lot more that's going to be said about them in the future. So for those with an interest in the chest, keep an eye on the literature. There will be more, and I think the outcomes of a big study done between Rotterdam and Amsterdam, which is ongoing, will give more clarity about the long-term outcomes between operating up front versus watching and waiting. Thank you, Milind.
Thank you for your comments. And I'm sure I can add to that genetics of these lung lesions is going to evolve further, and we will know more about their etiology and may also assist in antenatal diagnosis and treatment. But Dirk, thank you. Neha, well done with the presentation. Thank you for your comments, Dirk. Even though we can't meet physically, at least we could meet on Zoom. And as soon as the COVID nonsense is over, we all in East London are eagerly waiting for you, if possible with your family, to visit all of us in East London. And I really want to thank all our colleagues, not only from our country, but also from the rest of Africa. And as far as New York and the Guyana and the West Indies, who have taken time to attend these meetings. We really appreciate your presence and your participation. Next week, Dr. Daniel Irvi will present about spleen and surgical problems associated with spleen. And Dr. Ash Maharaj, who is a consultant pediatric surgeon in Durban, South Africa, will be our invited guest. So we hope to see most of you and many more for our meeting in a week's time on next week, Tuesday, 20th of July at same time. Have a good evening. Bye-bye now.